Chapter 14 covers agents that are used in common ailments of the eyes, ears, throat, and mouth. You'll notice when you open to Chapter 14 on page 173, there is an extensive table of medications that are broken down by site use, aka eye, ear, throat, and mouth, and then specific classes within each of those part of the body sections, we'll call it. I think it's important that students pick a couple of agents on these tables to focus on and to become familiar with. My recommendation would be to know ciprofloxacin eye formulations and tobramycin eye formulations, as those can be used to treat a variety of common complaints or issues with the eye, and understanding how they work and how to prescribe them is going to be helpful to you in your practice. The histamine H1 blocker that we see most often in practice is olopatadine or Patanol or Pataday. That agent is used for patients experiencing allergy symptoms of the eye. I think then it is also worth noting that students should be familiar with the ear formulation of Cipro-HC, that's ciprofloxacin with hydrocortisone suspension. And then the throat or oral agents that are worth noting in this chapter would be nystatin, clotrimazole, and chlorhexidine gluconate. So you'll notice that these agents will pop up as we move through the slides in this chapter. When talking about ophthalmic infections or issues, the most common eye ailments that are seen in primary care are infectious conjunctivitis, which is bacterial or viral in origin, or seasonal allergic conjunctivitis. Many of the other eye ailments that occur are outside of the scope of care in primary practice and are referred to ophthalmologists. I'm speaking, of course, about glaucoma, cataracts, and other common ailments of the eye, but things that are not treated in the family practice or primary care setting. Bacterial conjunctivitis is commonly caused by organisms such as strep, staph, Haemophilus influenzae, Moraxella, or Pseudomonas species. When we think of bacterial conjunctivitis, we think of an eye that is often weeping a lot of purulent discharge, or eye boogers, or pus, as parents might refer to it. Bacterial conjunctivitis is commonly spread through contact. We know that anything bacterial is often treated by an antibiotic, and we'll get to that in the next slides. Viral conjunctivitis is the most common type of conjunctivitis and is often caused by the adenovirus type 3, referred to as pink eye. In these cases of conjunctivitis, the eye is very red and accompanied by large amounts of clear discharge. This made me actually stop and think for a moment, because when I was a child, pink eye was classic when you woke up and your eyes were quote-unquote crusted shut. That was not typically a clear discharge, but more of a purulent or pus-like discharge. It is not uncommon for both a bacterial and a viral conjunctivitis to strike the eyes at the same time. Viral conjunctivitis can last anywhere from several days to 3 weeks or longer, and it is very easily spread by contact. When we think of herpes zoster conjunctivitis or herpes infections of the eye, we know that those are different from regular viral conjunctivitis in that they usually affect only one eye, and they are often accompanied by a vesicular rash. A vesicular rash is a rash of small fluid-filled sacs. These sacs will then open and release their fluid onto the surface of the skin. That fluid then crusts over to a fine yellow film or crust. Allergic conjunctivitis then is the common problem that many patients with allergies will present with. Oftentimes allergic conjunctivitis is seasonal, but it can occur year-round for patients with allergies to dust or mold. The classic presentation of allergic conjunctivitis is itching and tearing of the eye. There is no appreciable difference between the effectiveness of the many antibiotics that are available for treatment of bacterial conjunctivitis. This is when it's your job as a practitioner to select a product that is easy for patients to administer, is broad spectrum in the organisms it will treat, because we know there are a number of potential organisms that contribute to bacterial conjunctivitis problems, and that is relatively inexpensive. If I were you, I would take a moment to reference my Tarascon Pocket Pharmacopoeia book. I have the 2014 Shirt Pocket edition, so ophthalmic agents begin on page 155 for me. This sets up the listing of the options that are out there for treatment of bacterial conjunctivitis. It indicates the cost of the medication, the common dosing frequency, number of drops for agents, and it's probably worth a few minutes for you to take a minute and pick one or two that you might be keeping in your arsenal for when you approach these problems in your clinical practice. Commonly, we will use antibiotics to prevent a secondary bacterial infection in a patient that is presenting with a viral conjunctivitis. So while we don't typically treat viruses with antibiotics, in these cases, because bacterial and viral conjunctivitis can go hand in hand, we will often see antibiotic eye drops prescribed for pink eye. In theory, any adverse reaction that a medication may cause when that medication is taken orally could also occur when the medication is given as an eye drop. However, systemic absorption of eye drops is generally very minimal. And as a pharmacist in practice, when I get alerts in our computer system that tell me, for example, that a beta blocker eye drop like timolol could cause systemic side effects for a patient, I almost certainly blow right past that alert, knowing that it would take an awful lot of beta blocker eye drop to even begin to affect a patient's heart rate or other cardiovascular status markers. So I bring that up because you'll probably get warnings in your practice, but common sense leads us to believe that the likelihood of systemic adverse effects with eye drops is incredibly low. I'd also like you all to keep in mind that one drop of medication is all that the eye can retain. Writing a prescription for a patient to instill more than one, at the maximum 2 drops into an eye, is just wasteful and potentially very costly for the patient. You aren't getting more medication to the eye when you instill more than 1 drop into the eye. The use of 2 drops is sometimes necessary if a patient blinks before the medication can hit the eye, so that you can ensure that the eye is bathed in the medication. A second drop might be necessary. Ophthalmic agents come in a variety of formulations: ointments, suspensions, and solutions. And here at the bottom of the slide, I have indicated which ones are how they are absorbed in order of completeness. So ointments, because of their viscosity and their nature to stick to the eye, are most completely absorbed, followed by suspensions, and the eye dosage formulation that is least absorbed by the eye is a solution. The usual duration of treatment for a bacterial or a viral conjunctivitis is roughly 3 to 5 days, but treatment can be extended for up to 7 days. Generally, you're going to want to treat both eyes if the patient has an infectious conjunctivitis, because of the proximity of our eyes to each other and the way that we are constantly touching our eyes and our face. It would be more likely to spread the infection to both eyes than to prevent it from spreading. Specific viral infections should be treated based on the offending infection. For example, herpes simplex is treated with an antiviral ophthalmic preparation. That is outside of the scope of our practice in terms of family providers in the nurse practitioner setting, and so those infections will often need to be referred to an ophthalmologist. In viral conjunctivitis, artificial tears, topical antihistamines, and cold compresses may alleviate some of the symptoms. So the itchy, uncomfortable feeling of the eyes, the dry feeling of the eyes that can sometimes accompany viral conjunctivitis, and then cold compress to help reduce some of the actual swelling and inflammation that can occur with these infections. Switching gears now and focusing on allergic conjunctivitis, the goal in therapy, or the first-line treatment, should actually be systemic and nasal treatment of allergy symptoms, because those can control or eliminate the ophthalmic symptoms that patients might be experiencing. First-line ophthalmic agents that are used to treat allergic conjunctivitis include topical histamine receptor antagonist combo products or nonsteroidal anti-inflammatory agents. The NSAIDs as solo agents are less effective than the antihistamine combos. An example of an NSAID ophthalmic formulation would be Ocular or Ketorolac, and the common dosing regimen for this would be 1 drop in each eye twice daily. So I've indicated there how this could be written out as a prescription. An appropriate abbreviation for drop is GTT. The abbreviation for each eye or both eyes is OU, and twice daily is indicated as BID. We'll take a moment here to talk too about the different abbreviations for left eye versus right eye. OD is the abbreviation for right eye, and OS is the abbreviation for left eye. Now, there is a strange way in which I remember that. I am left-handed, I am not sinister, but for some reason it makes sense for me to remember that left-handed people are sinister. Therefore, OS indicates left eye. Hopefully you got a little chuckle out of that. This slide is an excerpt from the reference or database of UpToDate. This is a table that is present when you search for treatment of conjunctivitis. So this table breaks down the agents used in conjunctivitis as an empiric approach, specific approaches for bacterial conjunctivitis, viral conjunctivitis, and then allergic conjunctivitis. So you'll see that I've put in a couple of notes here with the red arrows. Trimethoprim polymyxin B ophthalmic drops are a great general first-line broad-spectrum agent to treat a presumed bacterial/viral conjunctivitis. The dosage the dosage instructions are also outlined in this table. So for Polytrim, you would indicate that the patient should use 1 to 2 drops 4 times daily for 5 to 7 days. Again, anything more than 2 drops is excessive and unnecessary. If we move further down in this table, fluoroquinolone ophthalmic agents are noted to be preferred for patients that wear contact lenses. So it's good to keep one of these in your arsenal as well. I've indicated that siloxane 0.3% or ciprofloxacin ophthalmic solution is a good option here. Generally, these medications are used as 1 to 2 drops 4 times daily for 5 to 7 days, but the specifics of the medication can be looked up in your Tarascon's Pocket Pharmacopoeia. Cruising down this table to viral conjunctivitis then shows that you can use an antihistamine decongestant drop combo. I've indicated that there are a couple of over-the-counter products that are useful in this setting. Nafcon A or Visine A have the nefazoline and phenyramine products as combined in this eye drop. Lastly, allergic conjunctivitis can be treated with a mast cell stabilizer antihistamine combination. 2 examples I've given are Zatador, which is ketotifen, that's available over the counter and it's inexpensive, or Pataday olopatadine, which is one that we referenced at the very opening slide of this chapter, is available as prescription only and is more expensive, but will also be useful in patients that have failed the over-the-counter trial of something like Zatador. You'll notice in this presentation that there's going to be a few slides about patient education, instructing patients how to use the various formulations of products that we were talking about today. So the first one is patient education regarding eye drop use. It's important to note that some product contents may be absorbed by soft contact lenses, so it's important to educate patients to avoid wearing their soft contacts when using various ophthalmic medications. Even OTC products can be problematic. Visine, for example, can cause pupil dilation in contact wearers. So contact wearers should be looking for products that are noted to be okay to use while wearing a contact. Most commonly as well, we don't want contact lens wearers to infect their contacts or have the organisms that are causing the conjunctivitis issues in their eye live on their contacts. So it's best advised for those patients to remove their contacts for the duration of treatment with an ophthalmic medication preparation. In order to educate patients on using eye drops, you're going to want to instruct them on the following steps. Patients should tilt their head backward or lie down and gaze upward. To instill an eye drop, the patient should grasp the lower eyelid below the eyelashes and pull the eyelid away from the eye to form a pouch. The dropper is then placed directly over the eye. It is important to avoid contact of the dropper with the eye directly or any area around the eye, as that can contaminate the eye drop. The patient should then look upward and instill a drop of medication into the eye. Immediately after instilling that drop, the patient should look downward for several seconds. Slowly releasing the bottom lid and gently closing the eye will allow the eye to remain bathed in the medication. A rapid blink of the eye could cause that medication to roll off of the eye and onto the eyelashes. With the eye closed then, the patient should apply gentle pressure to the inside corner of the eye where the lacrimal ducts are. This will prevent absorption and allow the medication that was instilled in the eye to exert a maximal topical effect. It's important to educate patients to not rub the eye or squeeze the eyelid aggressively after application of an eye drop, and to minimize blinking for several minutes so that the medication is not whisked away from the eye, which is the sort of protective mechanism that blinking offers. This slide will review the patient education necessary for eye ointment use. The same steps are followed for preparing the eye for ointment as we talked about in the previous slide, preparing the eye for drops. The patient should lie down and gaze upward. Gently pulling on the lower lid of the eyelid to again form a pouch, the patient will place a small ribbon of ointment along the inside of the lower lid. A continuous sweeping motion is used to ensure that one thin ribbon of ointment is applied to the eye. The lid is then slowly released once the ribbon of ointment is applied. The patient should then close their eyes for 1 to 2 minutes and roll the eyeball in all directions to ensure that that ribbon of ointment is evenly distributed on the surface of the eye. Temporary blurring of vision is very common when eye ointment formulations are used. Using these formulations before bed will help avoid the annoying consequence of using these types of products. To remove excessive ointment around the eye, gently wiping the eye with a tissue is recommended. Topical ear agents are used for superficial infections of the external auditory canal and for cerumen or earwax removal. External auditory canal infections are often caused by water in the outer ear, which is classically referred to as swimmer's ear. So it's important to note here that we do not typically use topical ear agents for things like childhood ear infections or even adult ear infections, as those are infecting the internal auditory canal. Cerumen or wax impaction is a hardening of the earwax that is often associated with old age. Nearly every nursing home medication administration record that reaches my desk in the hospital has an agent that is used on a PRN basis to help with hardened earwax in our elderly population. The anti-infective agents that are used for ear issues are available only as prescriptions, whereas the earwax removal agents are available over the counter. It's important to note that ear agents act topically with minimal, if any, systemic absorption. When treating one ear with an anti-infective agent, treatment of the other ear may also occur as a preventative measure. Anti-infective preparations often include an antibiotic plus hydrocortisone. The steroid hydrocortisone is added to help relieve the symptoms of the infection. And in fact, there were some studies that were done in children that had tubes placed in their ears, and treatment with the antibiotic agent alone was less effective actually than those patients that were treated with the antibiotic steroid combination product. So when I talked to one of my friends who is an ENT physician, he noted that it would be probably inappropriate to prescribe a solo antibiotic agent for an ear infection of a swimmer's ear or for childhood patients that had ear tubes put in place. They should always be treated with an antibiotic plus steroid product. When we use anti-infective ear preparations, they are typically used for 1 week only. So cortisporin otic solution, which is hydrocortisone, neomycin, and polymyxin, is one option for the treatment of ear ailments, but Cipro-HC otic suspension or ciprofloxacin with hydrocortisone is more common. These are used as 4 drops, 3 or 4 times per day. I'll tell you that one of my ENT friends, however, says 3, 3, and 3. 3 drops in each ear 3 times a day for 3 days, because that's a pretty easy regimen for just about anybody to remember. Over-the-counter preparations then that are used for impacted cerumen contain carbamide peroxide 6.5%. This is commonly referred to as Debrox. The treatment with these agents involves using these eardrops nightly in either both ears or the affected ear for 4 to 7 days, and then irrigating or washing the ear to remove that now softened wax on the 7th day. Sometimes it's necessary to use a product like Aluran in the ear, which is a combination of an anesthetic and an analgesic. So we have benzocaine to act as a numbing agent on the ear, and antipyrine acting as an analgesic, offering pain relief. We will sometimes see this used in combination with an antibiotic eardrop, for patients that are experiencing pain associated with swimmer's ear. The prescription use of Alguran is 2 to 4 drops 3 to 4 times a day as needed for pain. Patients can use that less often as the pain starts to subside. Patient education for the use of ear drops is as follows. Having another individual instill the drops into the ear canal allows for improved accuracy, as it would be next to impossible to instill eardrops into your own ear. Patients should be instructed to warm the bottle to body temperature, and that can be achieved either by holding the bottle in the hands for 10 minutes, which is actually probably more time than what somebody has. So another option would be to just carry eardrops around in a pants pocket all day, as that's probably much warmer than leaving them sit out on the counter. We want to warm eardrops to body temperature so that they're not as shocking when we instill them into the ear. If you're using a suspension formulation, it is recommended to shake the bottle vigorously for about 10 seconds to mix that suspension well. Patients should then lie on their side or their back with the affected ear up. Based on the anatomy of ears, when you are instilling eardrops into a child, you should pull the ear down and back, and when instilling eardrops into an adult, the ear should be pulled up and back. You can then easily visualize the canal into which you want to place the drops. Instilling the prescribed number of drops into the ear is the next step, and then immediately plunging the cartilage, or that triangular fold of skin that sits over the opening in your ear, will help work the solution down into the ear canal. The ear should then be kept in a tilted position for 2 minutes, or a cotton plug can be inserted to help prevent the solution from trickling back out of the ear. In instilling eardrops into my own daughter following tube placement, it was next to impossible to keep her tilted for 2 minutes, and when I inquired about this with the doctor, he said that once you plunge the solution into the ear, it's basically in there, and there's not a whole lot that's going to make it come back out. So that's food for thought as you're educating patients on the use of topical ear solution products. We will finish up this chapter with a brief review of topical mouth and throat agents. Commonly, antifungal agents are used to treat various fungal infections, such as thrush, that can be associated with antibiotic treatment or is common in immunocompromised patients. The antifungals that we most commonly use topically include nystatin and clotrimazole. These are available as both a suspension and oral troches. So nystatin, oral suspension or oral solution, is something that is used as a swish and spit or a swish and swallow formulation 4 to 5 times a day. That is typically used for oral thrush. Sometimes if thrush is resistant to the nystatin, or if patients have a hard time with the suspension, swish and swallow, or swish and spit, we can use something called an oral troche. That's a dissolving lozenge that contains an antifungal medication called clotrimazole. Those are lozenges that are allowed to dissolve in the mouth 5 times per day. Sometimes we need to use a cleansing or an antimicrobial agent in the mouth. A very good agent that has microbicidal activity that is used as a vigorous swish is called chlorhexidine gluconate. In the hospital setting, for example, we use this to help eradicate any oral germs that might be living in patients that are intubated. So because they're not really swallowing and kind of clearing the organisms out of their mouth on their own when they're intubated, we will swab their mouth with a chlorhexidine gluconate because it has bactericidal or bacterial killing effects to help get rid of the germs that are living there. Additionally, hydrogen peroxide can be used because it releases oxygen on contact with mouth tissue to provide a cleansing effect. This can be used after meals and at bedtime for patients that need help kind of debriding or cleaning an area in their mouth. This final slide is just extra bonus information for all of you today. Biotene, which is the picture on the left-hand side of the screen, is a popular brand of toothpastes, mouthwash, and other oral care agents that are useful in patients complaining of dry mouth. So I bring this up here because as we move throughout the semester, and even if we don't touch on it in a lot throughout the semester, I know you're going to hear about it in your clinical practice settings, that various medications can cause dry mouth for patients, and that can sometimes be very problematic. But Biotene is a brand of products that actually are formulated to target dry mouth and to offer a lot of relief for patients that are complaining of dry mouth. The picture on the right then is an over-the-counter product version, if you will, of hydrogen peroxide or chlorhexidine gluconate. It's called Orajel mouth sore rinse, and it causes that kind of bubbly hydrogen peroxide feeling in your mouth. We use it at our own house for canker sores, or when you bite your cheek and keep biting in that cheek, it seems to always be flared up after that. So this actually works to kind of help heal and cleanse those mishaps, if you will, that can sometimes occur in the mouth. If there are any questions regarding today's PowerPoint presentations, don't hesitate to post them to our discussion forum in Moodle or to email me and I will respond to the group. Thanks very much.